Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. In this series of the lecture about mitral valve regurgitation, for technical issue and some other reason, I am going to prepare and finish mitral valve regurgitation in three parts. This is the first part, anatomy and mechanism. Second part will be cardinal manifestation. And the third, echocardiography evaluation, technical aspect, detail, eccentric, concentric, all those questions, everybody has it. I'm going to give a very detailed explanation on that. First, part 1 and part 2 will be public, but part 3 only available for the member group. Let's do it. ASE has released a lecture by Dr. William Zogby. It is very detailed about valvular regurgitation. I strongly recommend go YouTube and check it out. In this presentation, I just try to focus some aspect of the mitral valve regurgitation, especially practical point from the most tech, ultrasound tech, echo tech, and some aspect of the cardiology and residents. Valvular disease, about 2% of general population have some kind of valvular disease, and when it increases the age, it goes up to 30% above 65 years old. Among those valvular disease that they come to the hospital and need intervention and some kind of treatment, the most common abnormality was aortic stenosis, about 40%. After that, mitral regurgitation, 20 to 30%, depending of the country, is a little different. And after that, aortic regurgitation. Mitral regurgitation, about 2% in general population, but with increasing age, it goes up to the 10% on people above 75 years. That most of them because degenerative disorder and all those stuff. What is the importance of the diagnosis of mitral valve regurgitation and especially grading? The most important part for the MR is detecting at early stage of severe regurgitation, because at that moment, if we treat, we can prevent for many complications, because after, if we don't catch it at that moment, later when it established, it come with the many complication. At top of them is CHF, that most of the time is almost always is irreversible, so we cannot return it back the patient life, and survival will be dropped hugely. So our point is that catching at early stage of the severe MR. Beside of that, for other grading, grade stage 1 and or mild or moderate, those help us that correspond this finding all other clinical symptom and echocardiographic finding. Does they match together about the symptom and grading of the regurgitation or not? So not that, okay, this MR mild or moderate, okay, it's not big deal. No, it's big deal. Just we have to, as a clinical practitioner, we have to know, okay, does those finding they make sense with those echocardiographic finding or not? Now let's go a short review on the anatomy of mitral valve. Mitral valve has a unique shape, semicircular, and spatial shape is completely unique and amazing. And most of this character is related to the arrangement and connection of the chorda tendini to the leaflet. Mitral valve has two leaflet, anterior and posterior. Those chorda tendini, we have three type of chorda tendini. Primary, that connected from the papillary muscle to most of the to the tip of the leaflets. The secondary, from the chorda tendini to the body of the leaflets. And tertiary are those that connected from free wall or septum to the, usually free wall, to the body of the leaflets. Sometimes this territory connected from free wall to the papillary muscle. So this arrangement, it gives very strong function and structure of the mitral valve. And you can imagine if one of or some of those is become loose, like the degenerative fibroelastic disease that happen in the MVP, mitral valve prolapse. Some of them, they become loose, elongated, and this bulging, one part, small part or scallop bulging out, and sometimes coaptation become dysfunction, and we have regurgitation or rupture of this, or rupture of the papillary muscle. Here, if you look at the end surface, surgical end face of the base of the heart at the level of the valves, you can see mitral valve orientation and relationship between all those and our echocardiographic plane. Here we have a plaques or apical tree. Our plane passed through exactly this line. So when you look at the apical tree or plaques, you know, okay, the anterior one is apical scallop 2, posterior will be scallop P2. Or in apical 4, you can imagine the valve, that leaflet that is close to the septum is apical, usually anterior 2, and the lateral one is between posterior 1 or posterior 2. Those scallop and leaflet that you can see in apical 4. Or in apical 2, depending what plane exactly you are in, or cutting surface or line, you will see different. If you are a little more to the medial, you can see almost only all leaflet that you can see is anterior. Maybe you can see part of the P3 or posterior 3. Or if you go a little more, you can see some other part of the posterior. But usually in apical 2, we see major one is anterior leaflet. Let's look at some expression on the mitral valve in echo views. Here we have a different view of the mitral valve in 2D, 3D, short axis and long axis. The reason I brought here in, as you notice on my presentation, because I want you, your mind get used to the feature and pattern and shape, and create an imaginary 3D each structure that I am going to talk about. That it's become very easy, little by little easy, when you look at them, completely make a good picture in your mind. Here we have in plaques, as you can see, anterior leaflet, posterior leaflet. You can appreciate some chorda tendini connected to the leaflet. Maybe sometime you can see posterior papillary muscle, posterior medial papillary muscle here, if a little you are off axis. Here we have apical 4. You can see both of them, anterior and posterior leaflet, coaptation, bulging out, all those characters. Here, the typical pattern of the apical 2, you only see one leaflet that is anterior. Maybe you can see a little posterior, one scallop of the P3, maybe, but most of the time, no. If you're fanning left and right, maybe you can see that type. Here we have short axis, is very typical pattern of the fish mount of the mitral valve, anterior and posterior, and you can see we have significant MR when you see this negative shift, usually MR depending of the what level of the view, but most of the time if you are in classic short axis view, you can see negative shift blue when the mitral valve closing. And so based on keep in your mind this image, later we talk about that. The most of the time regurgitation is not circular shape, is exactly elliptical, and that is the reason most dose quantity or semi quantity are not accurate. Later we talk about that. Here is a little classic typic of the 3D on TEE. You can see anterior and those scallop and how much the longer anterior leaflet and posterior how much narrow but wider, narrow and long. 2/3 of the mitral valve annulus belong to the posterior, but the width of the is very narrow. Those scallop, you can see it here. We have a mid-esophageal three-chamber view, just reverse of the plaques or apical tree. Just imagine upside down. So this is RVOT, aorta, and anterior mitral valve leaflet, posterior mitral valve leaflet, and so on. Now you get some imagination of those relationship and the mitral valve leaflet. Let's go to the mechanism of the mitral valve regurgitation or pathogenesis of the mitral regurgitation. As you can guess easily, the correct function of the mitral valve depends on itself, structure, leaflets, ring, and structure and function of those components involved in the shape and function of the mitral valve leaflet, including chordae tendineae, papillary muscle, and finally walls and LV shape. If we look at the mechanism of the mitral valve regurgitation from pathophysiology aspect, we can classify mitral regurgitation in two groups: functional myocardial regurgitation and structural. In functional, there is not any serious or prominent obvious pathology on the mitral valve leaflet, but the other component we have some problem: chordae tendineae or papillary muscle or myocardium. At top of them, you can guess there is coronary artery disease, especially myocardial infarction in LV. When we have myocardial infarction, it can happen different ways. Sometimes papillary muscle rupture or remodeling of that wall change the arrangement of the mitral valve leaflets, and they cannot reach each other and cover each other very well, and so on. In structural MR, we have some pathology in the mitral valve leaflet. At top of them, you can guess is mitral valve prolapse or rheumatic disease, and so on. From a surgical aspect, we can classify by the Carpentier technique, method. In Carpentier, MR divided to the three type, 1, 2, 3, and the type 3 divided the subgroup type A and B. Let's go one by one because it's important to understand the mechanism when you are going to evaluate mitral regurgitation. It's very important. You have to keep in mind what mechanism we are dealing when you are evaluating a patient with MR in echo. In type 1, we have some problem with the LA or LV size. In other words, mitral valve leaflet doesn't have any abnormality, but the ring has been expanded and dilated. Imagine when we have enlargement of the left ventricle, at top of them, very typical cause of that can be dilated cardiomyopathy. when the left ventricular enlargement, the ring expanded, but the leaflet, they don't elongate it and doesn't expand. So they cannot reach each other, and we can have expected to have MR depending of severity. Will have different grade of the MR. Or in a LA enlargement, for example, related to the AFib or consequence of other cause like the AI or anything, when we have enlargement or LA stenosis, whatever, when we have those enlargement situation on the LA, so we can see in advanced stage we have some degree of the MR. In type 2, we have some kind of the disorder and degeneration disorder in the mitral valve leaflet or chordotendiny. At the top of them, there is a mitral valve prolapse, a classic mitral valve prolapse. In this case, that usually is age-related, like the other age-related changes that happen in the skin, that we lose the collagen and fibrin in the subcutaneous and connective tissue disease. In some percentage of the people, 10% almost, with aging over 60, some part of the mitral valve leaflet, especially P2, the most common place, but any of those spots can happen. It becomes thinner and bulging, and the chordotendiny related and connected chordotendiny to that scallop become thinner and weaker and loose and become more flaccid instead of being rough and strong. So it can bulge out, as you can see here, bulging normal. I'm going to explain how you can see in the echo, but here bulging, when it advances stage, that bulging is too much and doesn't let coaptation or kissing those two leaflets together and cover the orifice. So finally, we will have some kind of the mitral regurgitation. In advanced stage, sometime one of the chordotendiny rupture and can cause flail mitral valve leaflet, that is usually the end of the spectrum of the mitral valve prolapse. Another type of the mitral valve, degenerative mitral valve prolapse, is Barlow disease. In this type, that usually happen at middle age, below 60, 40 to 50. In this case, not only the mitral valve leaflet become thicker, and some chordotendiny become thicker too, but it become losing, and so finally it gives the same impression and result to cause MR. In type 3A, we have some kind of degenerative disease in the mitral or inflammatory disease in mitral valve leaflet, at top of them rheumatic disease and maybe radiation. In those process, the mitral valve become calcified, thickening, adhesion together, narrowing, and many times it comes with the MS and shrinking. All those things can cause not coaptation and covering each other, those leaflets, and finally become incompetence and give mitral regurgitation. In type 3B, we have some kind, in this type, the structure of the mitral valve and connective tissue and everything almost normal, but the other function and structure involved with the function of mitral valve has problem. That is exactly the same correspond with the functional MR that we talked before. Another one that we can add to this group is SAM or cardiomyopathy, hypertrophic cardiomyopathy, that at one specific subtype of the hypertrophy HOCM, we have SAM, systolic anterior mitral valve movement, that I'm not going to talk about this type in this lecture. In another, completely another lecture in cardiomyopathy hypertrophic, we are going to explain in detail. Just remember, most of the or majority of the SAM is anterior mitral valve leaflet, but there are some few report that it can happen to the posterior mitral valve leaflet too. Now let's see how exactly we can expect the mitral valve prolapse on the echo. The echocardiographic feature and diagnosis of the prolapse is very easy. We do it on echo. In the normal situation, the contact and touching the tip of those two leaflets, mitral valve leaflets, is anterior to the annular mitral valve plane. Here, this is coaptation spot, and this is annular plane. How we get annular plane is easy. On the plaques, go back and forth. The spot that mitral valve move around that spot, bending and opening, we call it hinge. And in the posterior and anterior, and connect those two hinge together, that will be your annular plane of the mitral valve. In the normal situation, the coaptation or kissing or contacting tip of those two leaflets anterior to that. In the mitral valve prolapse, one part or two parts, doesn't matter, go beyond the annular plane. If it's more in the plaques, if it's more than 2 millimeter, we diagnose mitral valve prolapse. In the case of the flyel valve, the coaptation disrupted. We lose coaptation. As you can see here, the tip is not contact with the tip of the posterior mitral valve leaflet. So we have flyel mitral valve leaflet, and it gives you severe MR. It will be very obvious. Since I am here, I want to explain another term they use a lot. I want to make it clear for everyone. That is tethering. Tethering, in short explanation, is bulging. That's it, very simple. Here in normal coaptation plane of the mitral valve leaflet, almost flat or a little straight, but not bulging out or bulging in. On the myocardial infarction, especially chronic, we have the dependent which wall is involved and which chorda tendini involved. During systole, that chorda tendini that connected pulling toward the left ventricle, the center, so it's kind of the bulging toward the left ventricle. We called it tethering. This tethering, misalignment, coaptation, and cause MR. Here, the feature of the tethering in echo, we can appreciate very easy on the apical 4 here. We have anterior mitral valve tethering. You can see a little bulging out here compared to other one. It gives you the pattern feature of Siegel sign. Yes, kind of Siegel sign. That's it. Here we have a case of a mitral valve, interesting case actually. As you can see very easy, the posterior mitral valve leaflet is bulging during systole, and here on the mitral valve M mode, you can see posterior mitral valve leaflet bulging posterior or out during systole. That is a typical pattern of the M mode and 2D for the MVP. If you look at here, you see some MR, but I want you to focus and freeze it and go back and forth. And can you tell me exactly what is the mechanism of this MR? Let's show you another clip, apical 4. It's the same patient. If you can see, there are two jets in different moments. Go back and forth and think about this. I will talk about this at on the section of echocardiographic evaluation of the MR in the third part. So we are done with the first part of the MR series. If you put your answer about that case, will be great on the comments. I will read them, and I know better for that the third part explain what is going on, and it's kind of the interesting to understand when you do echo. Up to next time, have a wonderful time.